Hi, everyone, and welcome to the CCSP monthly call for June. We just have everyone joining and getting their audio connected, so we'll get started in just a few seconds. All right. Well, it looks like we have about 17 folks on for now and expect that more will be trickling in, but we have a pretty packed agenda today and are really excited to welcome Dr. Debbie Dyer from National Jewish Health, who will be sharing a little bit about lung cancer screening implementation and navigation to build off earlier presentations that she's done about lung cancer screening for CCSP. So some really great food for thought for those that are thinking about initiating the components of lung cancer screening and how the navigation piece fits in. But before we get into her presentation, I did want to just make a few announcements as we're approaching the end of the current fiscal year. That'll be ending at the end of June 2023 or 2022. And then we'll have one more year of funding starting in July that will go through June 2023. So as we're gearing up for the end of the year, just a couple of reminders. First, that all of the evaluation data and invoices are coming up for being due. So final evaluation reporting for the end of the year will be due on July 10th. And then all invoices for CCSP will be due by July 22nd. And then I also did want to let everyone know who's participating in any of the capacity building opportunities for either the stool-based testing, the hereditary work, or lung cancer screening, that our finance team has started to initiate those work order payments. That will be one lump sum payment for the work you all have done this year. And so emails have started going out with confirmations of those that are coming from CU as purchase orders. So that's what that work is for. And then we also have small awards just for our continued sustainability work that went to all the clinic systems, whether or not you're doing the capacity building. And all the deliverables for the capacity building work will also be due by July 10th at the latest. So I've been in communication with each of the clinics, but just wanted to make sure it was clear what those payments were for, who they're coming from, and that checks for those will be sent by the end of the month. Also, I wanted to remind you all and let you all know now that as we have done in each of the previous years, we have an end of the year survey for all clinic systems. And so especially as we're gearing up for the final year of CCSP and really want to make sure we're providing you all with resources that will be helpful for colorectal cancer, lung cancer screening, and hereditary, that we'd really appreciate that all clinic systems fill out the survey by the 24th, and Rena has just put it in the chat. At least one person per clinic system, but we'd welcome as many people for each clinic system to fill that out. So let us know what you'd like to see for the next year, what you want help with, and how we could continue to support you all beyond the end of this grant cycle. And then finally, just two announcements of upcoming events and webinars this month. So for our peer sharing series that is in partnership with the Colorado Cancer Coalition, the next one will be on the 15th and focused on an overview of different implementation toolkits. So there's going to be one around colorectal cancer screening, one around lung cancer screening, and then I'll be focusing on the sustainability toolkit as well. And then our final resource fair for this fiscal year is going to be focused on resources for patients that are undocumented, and that's going to be on the 21st at 12 p.m. So Rena's also putting the registration links for all of those in the chat. So please reach out to me if you have any questions about any of these end of year deadlines, what we need from all of you for deliverables or any of these events. And I'll be happy to meet with all of you one-on-one as well. So to make the best use of the time, that's all I have for announcements today. And we'll be sending all that information in the follow-up as well. But as I'm turning it over to Debby, who's the chair of the lung cancer screening program at National Jewish Health and has been a wonderful partner and proponent for lung cancer screening and helping us provide you all with training and technical assistance. I'd love for everyone to give her a warm welcome and put your name and where you're joining from in the chat, as well as your role, so we can see everyone who's here with us today. So I'm going to now turn it over to Debby to share her screen and begin her presentation. Thanks, everyone.
Okay, thank you, Elsa. And so I am attempting to share my screen. Can you all see this?
Yes.
Okay. Well, it's a pleasure to chat with you today and provide you some updates on lung cancer screening. I do have some disclosures. I am a consultant and speaker to the Lung Ambition Alliance. I'm also on the clinical advisory committee for Imadex, a software development company for AI, and I am on the GO-TO Foundation for Lung Cancer Scientific Advisory Committee. So today we're going to go through just a little bit of background and rationale for lung cancer screening CT. I'll review the latest recommendations from the U.S. Preventive Services Task Force for lung cancer screening and share some information about the new Medicare national coverage decision. We'll talk about the current status of lung cancer screening in Colorado, describe the necessary infrastructure for a screening program. I'll mention a little bit about LungRads, which is the structured reporting system for lung cancer screening CT. And of course, then there are a few barriers that we need to address. So lung cancer, as most of you know, is the leading cause of cancer death in the U.S. It is the highest cancer killer, and it kills more people than breast, colon, and prostate combined. There are at least 9 million current or former smokers in the United States that are eligible for lung cancer screening, and we know that number is going up due to the latest recommendations for eligibility. Survival is clearly related to stage at diagnosis, and importantly, chest X-ray screening has been shown to be of no benefit. So it's almost worse to do a chest X-ray than nothing because it gives some reassurance, which is inappropriate. Early stage lung cancer is not visible on a chest X-ray. So we are looking for lung cancer when it looks like this at the early stage as compared to here on the right side where it is late stage. And the world of lung cancer screening really was launched with the results of the National Lung Screening Trial in August of 2011. This was a multi-center trial of over 50,000 participants. And it started in 2005. Patients received baseline CT and 2 annual screening CTs, and it showed a 20% decrease in the group of patients that received CT. Based on the results of that study, the U.S. Preventive Services Task Force back in 2013 recommended lung cancer screening with a grade B recommendation. At that time, the recommendation was patients 55 to 80 and a 30 pack year history of smoking. Last March of 2021, the task force revised their recommendations after reviewing the latest literature, and they dropped the starting age to 50 and the required pack years to 20, and they kept in place 15 years since quit. And some folks have asked, why did we get a grade B and not a grade A? Well, grade A requires a high certainty that net benefit is substantial. Based on the research to date, the task force determined there was moderate certainty that low-dose CT was of moderate benefit. But importantly, both grades A and B are important because of the Affordable Care Act. Then exams that are recommended for preventive services such as low-dose CT are required to be covered by commercial insurance and states involved in the Medicaid expansion program, of which Colorado is one. So the new task force recommendations in March of 2021 dropped the age to 50, the pack years to 20. They kept in place an upper age limit of 80 and 15 years since quit. And this strategy was felt to increase then the number of patients eligible by about 87% and particularly help to address some of the racial disparities, particularly in the Black population and Hispanic population. And this bar graph, I think, is a nice example showing actually lung cancer by smoking. And the pack years are along the bottom. And these columns in yellow show the African American population getting lung cancer at lower overall cigarette exposure compared to the white population. And so since the National Lung Screening Trial results were released in 2011, there have been a number of studies that have shown that certainly lung cancer can differ by race and ethnicity. And so these new recommendations are thought to help address some of those disparities. The good news in March of 2021 was also that the American Academy of Family Practice recommended lung cancer screening. Prior to that date, they had felt there was insufficient evidence, but now they are recommending it as well. Other recommendations for the task force were to continue screening on an annual basis, that age and smoking history should be used to determine eligibility rather than some of the elaborate risk prediction models. Some of you may be familiar with some of these risk prediction models where you feed information, even demographic information, into a software program, and then it'll provide a lung cancer risk assessment. It does take some time, and you have to have the software program and be trained to use it. And the task force felt that even though it was probably useful, it wasn't as clear-cut as using age and smoking history. Certainly, patients who are currently smoking should receive smoking cessation intervention along with their lung cancer screening CT. And shared decision-making is important. Also, that lung RADS provides guidance on which findings are suspicious. So then I wanted to share with you, this is fairly recent. In February of this year, 2022, Medicare then adopted similar guidelines to the U.S. Preventive Services Task Force. They also dropped the starting age to 50. They kept in place an upper age limit of 77, which Medicare has had all along. They did drop the smoking history to 20 pack years. They kept in place that a patient needed to be currently smoking or quit within the past 15 years. Also, certainly they need to be asymptomatic, no signs or symptoms of lung cancer, which may vary by lung cancer screening program. In my program, we use signs or symptoms of coughing up blood, so hemoptysis or unexplained weight loss as potential signs or symptoms of lung cancer. We do not use cough or shortness of breath because patients who smoke may in fact have a cough and be short of breath. Medicare certainly does still require an order for the CT. Now, I know many of you who may be doing lung cancer screening are probably involved in some of the counseling and shared decision-making visits that are required by Medicare. And so with their new NCD in February, Medicare did make a change. To be honest, it's kind of been confusing for some folks, so we're not sure how effective this is going to be. But one of the things they were trying to do was broaden the number or group of folks that can provide shared decision making. So up until February, Medicare required that it be a licensed provider. So it had to be a physician or a nurse practitioner or a physician assistant, something like that, someone who can bill for their services. Well, now Medicare is saying that a physician in their private office, if they want to delegate shared decision-making to someone else, to auxiliary personnel in their office, they can. So an MA could do shared decision-making, and then it would be billed incident to the physician's professional service. There's still some details to be worked out. I think Medicare was trying to expand the pool of people that can do shared decision making, but right now I think there's just a lot of confusion. So keep that in mind, but there is an effort underway then to broaden the group of folks that can do shared decision making. Certainly, I think most everyone agrees shared decision making is important. Medicare requires a decision aid still be used. Certainly the counseling needs to include the importance of adhering to annual screening, discussing other comorbidities, and the patient's willingness to undergo diagnosis and treatment should a cancer be found. The shared decision-making visit should also include counseling on smoking cessation. And the good news is, one good thing that came out of COVID is that these shared decision-making visits can be done through telehealth. The Medicare NCD also had made some changes in the imaging facility requirements. It did keep in place that a lung RADS type system needs to be used, a standardized reporting system. It did eliminate the requirement that facilities had to report radiation dose and the fact that smoking cessation interventions were being offered at the imaging facility. It also eliminated the requirement for participation in a CMS approved registry. Some of us in the lung cancer screening world were troubled by the elimination of the requirement for the registry because the registry is really our only quality effort to monitor lung cancer screening. But we know that the registry had been found to be a barrier for some programs, so there's some pluses and minuses there. So in summary, right now, the eligibility requirement for lung cancer screening is ages 50 to 80 for commercial and Colorado Medicaid, age 50 to 77 for patients with Medicare. Patients have to have at least 20 pack year history of smoking. They need to be currently smoking or quit within the past 15 years. They cannot have any signs or symptoms of lung cancer, and they need to be willing to undergo diagnosis and treatment. So that's quite a bit to remember, but these are the key points to remember. Now, the timeline for adoption of these new recommendations, the age 50 and 20 pack years, I can say that almost every commercial insurance plan in Colorado has adopted these new eligibility requirements. Colorado Medicaid, I'm proud to say, adopted them very early on, and Medicare has adopted the new requirements. Right now, they may hold the bills depending on the local Medicare advisor contractor, but Medicare is covering the new eligibility requirements. So where does Colorado stand in the big picture of lung cancer screening? I'm sorry to say that we are not doing very well compared to national. We're only screening about 3.3% of eligible folks in Colorado. Nationally, programs are screening about 4 to 12%. That's still dismal. That's awful. I mean, colon cancer and breast cancer programs are striving for 80% of folks getting screened, right? So we've got a lot to do. Plus, we know with the increased eligibility requirements or the changes that we're going to have more patients eligible. So we want to bring our lung cancer screening community together and try to get everybody on the same page and working towards getting more folks screened. So what are the necessary components? I think what is challenging in lung cancer screening is that it's not as easy as a patient self-referring, for instance, for a mammogram. Because for lung cancer screening, there really has to be some eligibility screening. If you will, it's sort of pre-screening for screening to see if the patient meets the 20-pack year requirement and the age requirement and the quit year requirement and so forth. There is a requirement by Medicare for a shared decision-making visit, and this needs to be documented. Certainly, smoking cessation resources need to be offered to patients. CT technologists need to be trained in the low-dose technique for CT. I don't really think that is a problem. There is a lot of information in the radiology community about how to do these low-dose CTs, but you do have to have your technologists on board. Radiologists need to be trained in interpreting the CT with lung rads, and they need to have some experience in lung nodule management. There needs to be some sort of IT infrastructure to send reports to patients and to track and remind patients about necessary follow-up. It's also helpful, I think critical, to have some sort of multidisciplinary team for review of cases with suspicious nodules. If it's a small program, there may not be the ability to have a full team on site, but there can be a nodule clinic setting where the physician and hopefully a pulmonologist can review cases with the radiologist and figure out important next steps. There does need to be a referral network for care escalation. Certainly, if a patient needs a PET CT or a biopsy, a lung cancer screening program or facility needs to know where to send those patients. And then it is important to submit the data to the National Lung Cancer Screening Registry. As I mentioned, though, that is now optional. Now, who's the team? You may not have all these people on site in one program, but they're all important and they need to be communicating with one another. Certainly critical at the very top is to have lung cancer screening program coordinators or navigators. It's also helpful, particularly in a centralized program like the one that I run at National Jewish. We have advanced practice providers that actually do all the shared decision-making and follow up with patients themselves. So we tell our referring providers, just send us the patient's name and contact information, and we can take it from there. We'll determine if they're eligible, we'll do the shared decision making, and we can provide the report and follow up to the patient and obviously circle back with the referring provider. The team needs to include tobacco treatment specialists. Our advanced practice providers are all certified tobacco treatment specialists. Certainly, primary care providers need to be engaged in lung cancer screening programs because they're one of the main referral sources. There needs to be a radiologist and an interventional radiologist and pulmonologist and interventional pulmonologist. Certainly, these folks are important for knowing how to manage lung nodules and how to biopsy some. An oncologist is important because certainly there may be some patients that end up with more advanced disease that will need to have oncology services. Certainly a thoracic surgeon is key because ideally with lung cancer screening, we're trying to find those early stage lung cancers that can be treated with a simple wedge resection. Some patients may not be surgical candidates, but they're still eligible and they can have radiation therapy. So a radiation oncologist is also very important. And then in any lung cancer screening facility or program, there needs to be buy-in from hospital administration or the finance team to help manage the revenues and costs of the program. Now, I mentioned a little bit about the shared decision-making. Among the things that do need to be documented are that, in fact, the patient is eligible. There needs to be discussion of the potential benefits and harms. There needs to be the use of a decision aid and then counseling about smoking cessation, annual adherence, the impact of comorbidities, and willingness to undergo diagnosis and treatment. In the potential benefits, certainly what we're hoping to do is decrease mortality from lung cancer by identifying lung cancer at an earlier stage. I can also tell you that lung cancer screening has been found to be very cost effective. It is cheaper to treat early stage lung cancer than late stage cancer. It may help the patient relieve worry about cancer. Lung cancer screening CT is a teachable moment for smoking cessation. And if patients can be shown their CT and see the results, they may not have a suspicious nodule, but there might be other evidence of smoking related disease on their CT. And identifying and showing this information to patients has been found to be a very effective moment for smoking cessation. And then we may find incidental findings on lung cancer screening CTs as well. Now, we do recognize there's some potential harms. We may find a nodule that looks suspicious, but it'll turn out to not be cancer. Well, that's good news, but it was found. And so there was some cost in certainly working it up, and the patient may be worrying about the nodule. There is the cost of the additional testing for a nodule. There may be complications of invasive procedures. There may be workup of incidental findings. There is some radiation exposure, but these are low dose CTs, and we're getting better and better every year with our technology and able to decrease the dose. So the low dose CTs are about a fifth to a seventh of the dose of a regular chest CT. There is the concern about overdiagnosis in that we may find an indolent, very low-grade cancer that wouldn't actually harm the patient. And so we're careful about not removing or recommending patients for surgery that may have certain cancers that don't have suspicious findings. So in the world of decision aids, there's some that are kind of complicated, like this, where it's multiple pages. These are available online, and there's a whole lot to choose from. But I will tell you that in my program at National Jewish, we have used this. It's a single page, it's a pie chart, and we think this explains pretty well to patients what they're in for, if you will, in getting lung cancer screening. So in our program, 79% of patients will have no suspicious lung nodule, and there'll be no follow-up recommended for a lung finding of a nodule. And so those patients will just return in 12 months for their next annual screening CT. About 16% of patients may have a nodule that needs CT follow-up. So that's typically a follow-up in 3 or 6 months. And about 5% of patients will have a nodule that looks suspicious enough that it needs to go on to biopsy. Biopsies are usually done through bronchoscopy or CT-guided lung biopsy. And then what is what we're trying to get after is about 1 to 2 of every 100 patients screened each year is diagnosed with lung cancer, and almost all of those are early stage. I can tell you in my program at National Jewish, 85% of the cancers we find through screening are stage 1. So lung RADS is the structured reporting system that the radiologists use. And it looks like this. There's lung RADS categories of 0 through 4X. And I'm just going to breeze through these pretty quickly. But basically, a negative screen is a patient that has no nodules or nodules that clearly look benign. And so these patients, we just recommend a follow-up CT in 12 months. There is a lung RADS category 3 of probably benign, but a nodule that needs follow-up. So this patient needs a follow-up CT in 6 months. And then the lung RADS 4 categories are the ones that are more suspicious. These are positives that need more intensive follow-up. Now, it may be that for the lung RADS 4A, we can just do a 3-month follow-up CT. Some patients might be appropriate for a PET, but certainly the 4B and the 4X nodules are the scary ones. Those are the ones that need immediate workup. They may need a PET, they may need a biopsy, they may need a surgical referral. And we know that the risk of cancer is much higher based on the appearance of the nodules in this category. And so here's an example of a lung RADS 4A. This was a nodule that was found out here in the periphery of the left lung. It's called a part solid nodule because there was some central solid component with surrounding hazy ground glass. It was recommended the patient come back in 3 months, and they did. And in 3 months, what you can see is that this nodule became much more solid and the margins are more irregular. And so now it's a 4X. This is highly suspicious. And so this patient did go on and have this worked up. It was biopsied. It was determined to be a cancer, an adenocarcinoma. The patient had it resected with minimally invasive surgery. And this was a stage 1, and the patient has been doing well since. Now, just a brief mention of incidental findings. The radiologist may use an S code in the lung RADS classification system. And that means that there's an actionable finding, an incidental finding that needs immediate or at least some medical attention. And so, for example, one of the most common incidental findings is coronary artery calcification. This is a cross section through the heart. And here we can see the left main coronary artery and the left anterior descending. Here we have a moderate amount of calcification. Here we have a severe amount of calcification in the left anterior descending. And the thought is both of these patients would probably benefit from statin therapy and certainly a clinical visit to see if there may be some symptoms and the patient could benefit even from further workup. Another opportunity is to find incidental masses. And so we actually can see the breast tissue on these low-dose CTs. And this particular patient had a new nodule in their left breast. This is an image, a blow-up image of that left breast, and you can see this nodule. This turned out to be a breast cancer, and the patient was able to have it resected, and the patient has been doing very well since. The American College of Radiology has a whole document on a guide on the CT incidental findings in lung cancer screening. And I'm going to be sharing this slide set with Elsa. And if you need a copy of this, you could print it off of the slides that Elsa will be sending you, or you can also go to the American College of Radiology lung cancer screening website. You do not have to be a member of the American College of Radiology to get a copy of this document. The other thing that I just wanted to mention briefly is that management of the care continuum is so important in lung cancer screening. So certainly we need navigators or advanced practice providers to make sure that patients do get the results of their CTs. I think having the multidisciplinary committee review of suspicious nodules is very important, and a referral network for the advanced workup. I mentioned a little bit about the ACR registry. It was initially required, but it is now voluntary, and it is the only source of quality metrics at this time. So we do encourage that facilities still participate. The ACR also has this brief one-page document. You can print it out on both sides, which just basically answers the economic and billing questions in lung cancer screening. Pre-auths are required by most commercial insurance in Colorado. Medicare and Colorado Medicaid do not require pre-auths. Just a bit about barriers. I don't want to run out of time, but I think most of you and anybody who's familiar with lung cancer screening know that we do have complex eligibility requirements. I think that's been part of the problem of the low uptake. It's required that we have a written order, unlike mammography, where a patient can self-refer. There is the prior authorization requirement for commercial insurance. I think we overall have a lack of awareness among patients and healthcare providers. We've got to work on that. The shared decision-making visit is very important, but we know that in some ways it's also a barrier. Smoking cessation is certainly important for the patients that are currently smoking, but some folks may view that as a barrier, having to provide that. And then we also know that our primary care providers are really overburdened trying to deal with a lot of issues. So centralized programs where there are advanced practice providers that can provide that shared decision-making visit and managing the care continuum can be very helpful. We've talked about the complex eligibility requirements. We talked a little bit about the referring providers being overburdened, and they may have a hard time identifying eligible patients. We want to make life as easy as possible for them. And then I think it's also important to mention about patient barriers. We're very aware that some patients may experience guilt and stigma about smoking, and they may just have a fatalistic view. And so we need to help them understand that lung cancer screening is open to everyone that is eligible. There is no one's going to look down on someone even if they're currently still smoking. Smoking is an addiction, and it needs to be dealt with as an addiction. And we certainly don't want to make patients feel guilty about any addiction that they might have. Patients may have a fear of having lung cancer. We do know there's also limited access in underserved areas, and particularly in the rural areas of Colorado, we know about that. Then there's financial barriers. Patients can get lung cancer screening annually at no cost. So there should be no copay and no application to their deductible. They can do that once a year through commercial insurance, Medicare, and Medicaid. But If they need follow-up, then they do have a copay. And we also know that there's other financial concerns of patients needing to take time off of work and so forth. So in summary, lung cancer screening is a team effort. It is a program, not just a CT. The updated U.S. Preventive Services Task Force recommendations and new Medicare coverage decision will help address disparities in lung cancer screening and increase the number of eligible patients. Structured reporting with lung RADs does allow us to have consistent reporting and lung nodule management. We also want to acknowledge that the barriers to screening are significant, but I think through a coordinated effort of folks like you all and other stakeholders throughout the state, we can make a difference. So I'll close there and answer any questions you all may have.
Thank you so much, Debbie, for another wonderful and very comprehensive presentation. I'd invite everyone to put your questions in the chat, and then I can give an opportunity to come off of mute in just a moment. And to get us started off, I was wondering, Debbie, if you could speak a little bit more about some of the specific opportunities for the role of the navigator, and particularly if you think there are any slight differences in what navigators could do in a primary care setting versus a hospital setting or a more centralized setting.
And that is a good question. And you know what? Navigators certainly vary. In some programs, the navigators are more lay navigators. In some programs, they may be folks that have limited medical training, but they have good person skills. And then at the other extreme, you may have nurse navigators who can really manage even the care continuum for patients. But I think the common variable among all the navigators is they need to understand the eligibility requirements. They need to understand how to get a patient in for screening. And I can just speak to the navigators in my program. We have two navigators that have great person skills. They're not medical. But they can schedule. They can certainly understand the EMR. They look at insurance. They deal with insurance companies on a regular basis, and the team of folks that can get authorization for patients to come in. They are also wizards at calling patients, getting in touch with patients, reminding patients, and then following up and making sure that the patients did get the report and that the patient has a follow-up visit scheduled. I think those are sort of the minimum we want our navigators to be able to do. And if it's a navigator that may be working with a special population because of language barriers, I think they also have a huge role in being able to interpret and making sure that patients are connected to programs that can accommodate patients with different language skills and so forth. So there's varying roles for navigators, but as a minimum, I think they have to know the eligibility requirements and be able to answer questions from patients, and then person skills and being able to communicate clearly are just so incredibly important, because we know patients have a lot of questions and they need to often be reminded what they're going to be doing. And so we invest a lot in having our navigators spend time on the phone with patients and then communicating also through our hospital portal system about reminders to come in.
Yes, the navigators play such a key role, and we're so thrilled to have so many of them connected to this work. And I'll be sharing in just a moment some of the video modules we've also finalized from our partnership with National Jewish Health. So there's some different role plays about shared decision making and some interviews with a former navigator at National Jewish. So many different resources in there for the navigation components as well. And also, Debbie, we've focused a lot on the initial lung cancer screening low-dose CT, so a first annual. Could you speak a little bit more about any best practices or different tricks you've noticed for getting patients back in for their repeat screens?
Yes, one of the challenges is adherence to annual screening. And we know that particularly during the height of COVID, all screening programs had a problem with adherence. That part may not be unique to lung cancer screening, but that is another very important role of a navigator. And so what is key to, I think, adherence is having some sort of a tracking system. And early on, if the program is small, it could be an Excel spreadsheet. But once you get into having 500 patients enrolled in your screening program, you just can't keep tracking patients on a spreadsheet. You need to have some sort of IT infrastructure. We built something, just an SQL database at my facility, where this system does send reminders to the navigators and to the patient and to the referring provider that the patient is due for their annual screen. And then the other thing we do is we send a follow-up email that if the patient is 1 month overdue, then they also get a reminder. So I think these kind of nudges are critical, and being able to communicate through the whole system of making sure that the navigators and the patient and the referring provider all are getting the same messaging, then everybody can work together to get that patient in. And then we went through a whole, when we resumed screening, we were down for 6 weeks during the height of COVID. But when we resumed screening, we did a lot to try to make sure the patient's visit was brief and complete and safe. And so it did take a while, I think, for patients to feel comfortable to return to a hospital facility or any imaging facility for that matter. But we're not finding that now. I think patients have moved beyond that. And so now getting patients in for their annuals, I think, is just an issue of nudging them and reminding them.
Yes, sure. Always so much communication that needs to happen. I'm not seeing any questions in the chat for Debbie. So I'm going to pause for a moment and see if anyone wants to come off of mute to ask anything, if that's easier. All right. Well, seems like Dr. Dyer, your presentation was very thorough, and so our attendees had their questions answered. Before I briefly just wanted to walk through our new lung cancer screening video modules that we have been working on for the last couple of years with the CCSP program, National Jewish, and Catch It in Time, a media production company. I wanted to give you an opportunity, Debbie, to provide any closing thoughts, especially as we're working with the CCSP program partners to build capacity and folks that are newer and thinking through all the complexities of implementation and just kind of those small details that really will help them with success for getting patients in for lung cancer screening across the whole clinic system.
Well, I certainly want to thank you all. Thank you for your attention today. Thank you for everything you do. I know that you all have key roles in our healthcare system. And if I can encourage any of you to be ambassadors, even if you're not ordering or in the role of navigating for lung cancer screening. If you can just encourage folks to get screened, I think that's also very important. And I'm happy to be a resource to anyone who may be wanting more information or starting a program. I have had a wonderful experience working with the CCSP program, continue to work with them. And so I think that this network that has been built is just incredibly valuable in promoting good health and preventive care and doing everything we can to decrease the burden of cancer on Coloradoans.
Thank you so much, Debbie. And we'll be working directly with you to help provide additional technical assistance in the next year. And all of you, please reach out to us and we can connect you with Dr. Dyer for additional support. So the recording and slides from our presentation will be posted on the CCSP website for our videos and recording section, especially our section on lung cancer screening. So I'm putting the link in the chat for that now. And then I just am going to share my screen briefly just to show you our supplemental lung cancer screening video modules. So these have been created directly in partnership with National Jewish, who helped us design the content for these. Debbie and her other colleagues are in many of these, as well as some of our partners here at the university, including Dr. Jamie Stutz. So there's several videos. They're about 2 to 10 minutes in length. And if you were to go through them in order, there's an introductory video really focused on the value of lung cancer screening and the role of primary care in particular. And then the first module is really focused on the eligibility criteria and shared decision making. So we have the updated eligibility criteria for USPS, TF, and CMS in here, and a quick overview. And then the one I really wanted to highlight is our role play of a shared decision making visit. So this was a mock encounter with one of the nurse practitioners at National Jewish, who does many of their shared decision making visits, and then a mock patient. And it really goes through a full conversation of a shared decision making visit that meets all of the requirements for billing for a shared decision making, but really being patient centered in the conversation and hearing from the patient. So I would definitely recommend checking that one out, if none of the other ones. And then we have the second modules focused on the value and challenges of lung cancer screening. So one video on the value with Dr. Jay Finnegan from National Jewish. And then one on some of the risks and benefits of screening and some more of those challenges. The third module is focused on the value and role of navigation for lung cancer screening. So a conversation with Debbie about the value, and then a video on perspectives from a former lung cancer screening navigator at National Jewish. And then the fourth module is focused on stigma in lung cancer screening. And Dr. Jamie Stutz here at CU is really an expert in this area. So he really spends some time talking through some of the stigmas that are common in lung cancer and lung cancer screening, and how we can help support patients and overcome these and reduce the likelihood that there is stigma. And then the final module is focused on some of the outcomes and incidental findings. So what are lung nodules, the different types of them, lung rads, which, as Debbie talked about, is how we categorize lung cancer or lung nodules on their level of risk and whether there needs to be additional workup and follow-up with those patients. And then some of those incidental findings that might come up during a low-dose CT and how they're managed. So those are all of the videos. I'd recommend you check those out and can share them with others in your clinic systems, including providers, nurses, and other roles. And I'd shared these ones previously, but we've also have our specific links to the navigation guidebook specific to CCSP and the recent navigation and implementation toolkit that was created by the CU Cancer Center and the Patient Navigator Training Collaborative. And that has a companion online course that you can go through at your own pace. So those are our new resources. Please let us know if you have any questions about them, and we'd be happy to walk through them with your teams. So that's all we have for today. I'll send a follow-up email to all our CCSP clinics with this information. But for those that are joining us from other organizations today, this information can all be found on the CCSP website that I've put in the chat. So thank you all. Have a great rest of your Tuesday, and we'll be in touch with all of you soon. Take care.